States used a paper record for the great bulk of my career. But a few years ago, 7 to 10 years ago, my healthcare organization in Boston implemented an electronic health record. And though I had no particular interest in technology up to that point, and wouldn't still consider myself a technologically sophisticated person, I immediately saw that using that record was changing the way I practiced medicine, and that it was making me a better physician, that I knew more about my patients, that I was able to respond to their questions better, that I was less likely to miss critical laboratory values, and more likely to know what else was going on in their medical lives. And not only that, but I found that it was making me a safer practitioner and a more efficient practitioner. So just as an example, I remember vividly the time when I was about to discharge a patient from the hospital and ordered a medication called Bactrim, a sulfa medication, for a urinary tract infection that the patient had at the time of discharge. And as soon as I entered that order in the electronic record, a red band came up on the screen and asked me if I knew this patient was allergic to sulfa medications. And I had overlooked that, and I will be forever grateful that that electronic record prevented me from ordering that medication. And I also recall another time when I was ordering a CAT scan on a patient to try to image a patient's kidneys. And as I entered the order in a system that my healthcare organization had, a message came up asking if I was sure that I wanted to order that imaging study, because it thought that there was another study that was done recently that might have the information I wanted. And sure enough, I found that on a study of the lungs, not of the abdomen, which is what I was ordering, but a study of the lungs, the kidneys had been imaged and were normal, and I didn't need that CAT scan. So I saved the patient the radiation, I saved the healthcare system the money of the CAT scan, and I think I delivered better and cheaper care to that patient. And I think those stories suggest what the potential is, how small victories, one by each, using the best information and the best supportive decision-making that physicians can have, can lead us to be better physicians, higher quality physicians, better for taking care of our patients, and doing it at lesser cost than at the current time. And if that's not a win-win for providers, for doctors and nurses and all health professionals and for healthcare institutions, I don't know what is. Let me move on a little bit to talk about the program that I'm tasked with implementing for the Department of Health and Human Services. I think the Congress showed terrific vision in enacting what's called the high-tech legislation, a provision of the Recovery Act that President Obama signed in February of this year. That historic legislation makes a commitment to making it possible for all patients in the United States to get the benefits of an electronic health record used by their caretakers over a period of time. There are two critical pieces of that legislation. The one that will most affect doctors and hospitals in the short term will be incentives that are available to providers who take care of Medicare patients or Medicaid patients. And those incentives, which total, according to the Department of Health and Human Service actuary, about $45 billion over a 7 to 8 year period. Those incentives will be made available on an annual basis, in particular increments, to doctors and hospitals who show that they are meaningful users of electronic health records. And I'll get back to what that means in just a moment. The other $2 billion is available to the Department of Health and Human Services and to my office to support physicians and hospitals in making it possible for them to become meaningful users. Now, the meaningful use term is a really important term. And we're spending a lot of time thinking about how to define that term right now. The legislation only does that in a general way. But it shows the intent of the Congress and the intent of this administration to use information technology to improve care rather than just to implement boxes and screens on physicians' desks and in hospitals' nurses' stations. It shows the intent that this equipment be used to make healthcare better, to be used in a meaningful way. Now, there are three major things mentioned in the law as defining meaningful use. The first is the ability to electronically prescribe. The second is the ability to exchange health information among different organizations and among different providers of care. And the third is the ability to report quality data electronically. Those are very broad guidelines. The first incentives become available in 2011 to healthcare providers, doctors, and hospitals. And the law makes it clear that the meaningful use criteria, the definition that is developed, should change over time. It might be a little less demanding in 2011 and maybe become more demanding over time on the way to a better performing healthcare system and improved quality and efficiency. Now, we have been working hard to define meaningful use, as I mentioned. We held an open hearing in April 28th and 29th, in which we had 2 days of testimony from people all over the United States about what meaningful use should mean. We had a meeting of an advisory committee, an open meeting of an advisory committee early last week, in which a working group of that committee presented an idea for a definition. The committee is going to work some more on that and reconsider it in the middle of July. There is a comment period now in effect that the public can use to make comments on those materials. And those materials are available on the Office of the National Coordinator website. And we welcome public comment on these definitions. We're also holding a series of listening sessions right now, about 20 of them around the country, in which we're inviting local providers and other groups, consumer groups, patient representatives, hospital representatives, to come in and comment on what they think meaningful use should consist of. We will have a rulemaking process, a very open, formal rulemaking process that will begin at the end of this year that will result in a definition well in time for the 2011 timeframe. We are doing some other things. We are trying to put in place the support systems that will enable doctors and hospitals to become meaningful users. We know that it's not enough just to buy the equipment. We know that to make this equipment work, you need technical support, you need help redesigning, one needs help redesigning their offices, redesigning workflows in hospitals. Without that kind of help, the technology itself will not achieve its objectives. And we are about changing the quality of care, improving things for patients and physicians, not about buying equipment. So we have a series of programs we're working on that we hope will provide in as many communities as possible support for exchanging information and support for setting up and using electronic health records in local communities, in practices, and in hospitals. Going forward, we're going to continue, as I said, to work on the meaningful use issue. We are also tasked by the Congress to develop the technical standards that will enable electronic health records to actually do the work that's expected of them, to communicate with other electronic health records, that is, to become interoperable. And we're also tasked with making sure that the standards for privacy and security are as exacting and tight as they can be within the constraints of making these systems do the work of improving care. Actually, before I came down here, I was at a meeting of another government committee, our Health Information Technology Standards Committee, which is meeting up 10 on Connecticut Avenue this morning, and was mapping out how to develop the technical standards that are required for alternative definitions of meaningful use. We face a lot of challenges. We face the challenge of creating an office in the department that is up to this task, a totally new task, a huge task, one that affects potentially every physician, every hospital, and every patient in the United States. We face the task of moving through multiple rulemaking procedures, getting spending programs up and running. It's all an enormous challenge, but one thing that gives me hope and sustains me as I think about this, and that is the feeling that what we're doing is ultimately supporting the professionalism of America's health professionals. Because in the 21st century, to be a competent professional, in my view, will mean being able to use effectively the most advanced information systems that we can muster on behalf of our patients. And that means using health records that are digitized and being able to communicate with other health records that are digitized so that the full capability of this web-enabled, technology-enabled society is mobilized for the support of our patients. I think that the electronic health record, or its next version, whatever that version may be, is going to be as core to medical practice as the stethoscope and the examining table. No doctor would think of going into practice without those, and I believe, especially for the generation of physicians who I was teaching before I came to this job, that will also be true for the kinds of technologies that we are trying to spread throughout this healthcare system. So with that,